conference live session. So my name's Howard Morris, and I have a joint appointment with the University of South Australia and the Assay Pathology, which is the major pathology service in South Australia. Today's presentation, I want to address the key issues for providing a high quality clinical service for serum 25-hydroxy vitamin D assays. I will welcome any questions that you have, and please enter them at any time throughout the presentation, and then I will address them at the conclusion. So we're talking about the measurement of serum total 25-hydroxy vitamin D is essential to assess vitamin D status. And the developments of a reference measurement procedure and a reference standards have improved the accuracy of many of the routine assays that are available for 25-hydroxy vitamin D. Amongst the experts, there's general agreement that there are benefits for assessing vitamin D status in specific patient groups, but population screening is discouraged and thought to be not cost effective. Certainly, vitamin D deficiency, and I emphasize that, deficiency, is associated with an increased risk of a wide range of diseases, including metabolic bone disease, cancer, decreased immune function, and increased autoimmune reactivity. However, I'd like to emphasize that the highest level of evidence is simply limited to demonstrating that adequate vitamin D status and dietary calcium intakes protect against metabolic bone disease, falls, and premature mortality. These data have come from randomized controlled trials where vitamin D and dietary calcium supplements were provided to the patients. And they were testing in the main that vitamin D and calcium would protect against fractures. However, these other aspects such as falls and premature mortality came out of such studies. So therefore we have not established whether dietary calcium or vitamin D status alone has any benefit on these outcomes. So this is the metabolic pathway for the activation of vitamin D, and you've probably seen this well before, but the points that I want to make is that the activation of vitamin D requires sequential hydroxylation steps catalyzed by different enzymes. Firstly, to synthesize the prohormone 25-hydroxy-D, which is inactive and in the plasma is largely synthesized in the liver. And then the second hydroxylation step synthesizes 125-dihydroxy vitamin D, and again in the plasma, the 125-dihydroxy vitamin D, the hydroxylation takes place in the kidney. And so therefore that produces plasma 125D, which is suitable for endocrine activity. That endocrine activity is exerted by entering the cells as described in this slide and binding to the vitamin D receptor, a nuclear transcription factor which then binds to chromatin in vitamin D responsive genes and initiates transcription of those genes. And these activities can regulate certainly calcium homeostasis, they do affect cellular differentiation and probably interact with the immune system. Now, a second biological activity or mode of biological activity for vitamin D is through an autocrine activity where the prohormone 25D actually enters the cells, and there it is converted again by the enzyme CYP27B1 to 125-dihydroxy vitamin D, and then it is this internally synthesized 125D which exerts biological activity. So therefore the prohormone is the source of both an endocrine activity through activation in the kidney to produce plasma 125D, as well as the autocrine activity where it enters the cells and is converted into 125D and acts within those cells where it's formed. Now, there are certainly difficulties and complexities with assaying serum 25-hydroxyvitamin D, and that is due to a number of reasons which I'll now discuss. First of all, we often are working with two slightly different chemical forms of vitamin D. As shown here on these structures, vitamin D3 or cholecalciferol, which is derived from animals, and derived particularly from cholesterol, as well as orgocalciferol, vitamin D2, which is derived from fungi and plants and has a slightly but significantly different structure, especially for immunoassays. Now, both vitamin D3 and vitamin D2 are metabolized to the 25-hydroxy and 125-dihydroxy metabolites. Only the serum 25-hydroxy metabolite indicates the vitamin D status, and the usefulness of the measurement of 125-dihydroxy vitamin D levels is limited and certainly limited to specialists in particular. Vitamin D status is indicated by the sum of 25-hydroxy-D3 and 25-hydroxy-D2, and equimolar detection of each of these metabolites is essential to report an accurate total serum 25-hydroxy-D. It's also important to recognize that the molecular weights of 25-hydroxy-D3 and 25-hydroxy-D2 are not equal. There's a significant, about a 3% difference. And therefore, if you're calculating the total serum 25-hydroxy-D from adding 25D3 as nanograms per mil and 25D2 as nanograms per mil, you will end up with a slight but significant error of about 3%. They should be added in nanomoles per litre because 1 nanomole of 25D3 equals 1 nanomole of 25D2. So, the difficulties encountered in measuring and providing a service for the serum 25-hydroxy-D assays include the following. It's a highly lipophilic molecule and therefore not necessarily easily transferred from the blood levels, the aqueous bases that we use. Also, in blood, 25-hydroxy-D2 is bound tightly to a binding protein, the vitamin D binding protein, or DBP. And when we're measuring it, we assume that there is a 100% displacement of the 25D from the DBP. But that is what we assume, and we have no evidence whether it's 100% in every assay or 90% in some assays. And then we have all these various metabolites that I've just described to you. We have the various hydroxy metabolites, 25D, 125D. We also have 24-25 dihydroxyvitamin D and the epi 25-hydroxy-D. And then we might, if patients are taking D2, we might have D2 forms of those metabolites and D3. So we have a very large number of closely related, molecularly related metabolites in which we're trying to measure just one of those. When we're trying to establish in-house assays, it's very difficult and we need to provide calibrators. And in the fact, for ourselves, in those in-house assays, we have to use calibrators in ethanol solutions. The preparation of these standards is difficult. If you add known amounts of 25-hydroxy-D to serum, and then assay that in an assay which does not have an extraction procedure, then you always get erroneous results. And we don't really know why, but we presume that there's inadequate equilibrium with the vitamin D binding protein, there's an inability to extract it properly, but it just doesn't work. And then we have other matrix interferences. And these can occur under various clinical conditions such as renal failure or pregnancy, and I'll discuss those specific interferences more later in this presentation. So the question then of the difficulties is well demonstrated by the variation in performance in external quality assurance assays and systems. And here I'll just spend a couple of slides describing the DQUAS data generated in, I think this is 2013, but it's the major external quality assurance program that clinical labs subscribe to when providing assays for 25-hydroxyvitamin D. And then you can see that at this time there's some 1,083 participants. Now, there's a lot of assays, so let's just focus in on a few of those assays. And so these data are demonstrating that accuracy is a problem. So with target value set at some 36.2 nanograms per mil, the various assays generated values ranging between 32.6 to 46.2 nanograms per mil. Quite a variation. As well, precision is a problem. And there you can see that the imprecision is measured as percent coefficient of variation, or CV percent, ranges between 6 and 20%. So these difficulties have been certainly recognised over a period of time, and the international community, and in particular various organisations, took it upon themselves to try and provide some relief. And this was called through establishing the Vitamin D Standardization program. It was coordinated by CDC in Atlanta, NIST, and the University of Ghent in Belgium. And there they had 30 serum samples obtained from apparently healthy single donors. They collected a significant amount of blood and serum from each donor. They then measured the 25-hydroxy-D level using the specific LC tandem mass spectrometric reference method. So not just any or a varied LC-MS-MS method, but the reference method that had been assessed as providing the optimal analytical device. They then distributed these serum samples across participating laboratories to calibrate both commercial and in-house methods, as well as all the in vitro diagnostic immunoassays. And then they distributed a verification set was conducted on 4 sets of 10 samples in 2013. Acceptable bias and imprecision were found and achieved through this program, with a bias of plus or minus 5% and CV of plus or minus 10%. Now, some very interesting data have been published just earlier this year in ClinChem Acta by Etienne Cavelier from the University of Liège in Belgium. And I'll present these to you. He established the LC-MS tandem mass spectrometric reference method in his own laboratory and verified that it was working optimally. And then he collected some 186 patient specimens from those that had been submitted for routine assays in his laboratory. Incidentally, there was no 25-hydroxy-D2 detected in any of these samples. So initially, he measured these 186 also by LC-MS and by 5 routine immunoassays from the Architect, Centaur, the Alexis, the ISIS, and the Diasorin liaison. And then he related the values obtained by LC-MS to each of those, to the values obtained from each of those commercial immunoassays. And what you can see there in that table is, first of all, the slope of the relationship described by the 2 various assays. And you can see that basically there's a significant variance from 1. 1 is what we're after. We want a 1-for-1 relationship. But for architect, there was only 89% of the value obtained by LCMS. For the centaur, it was 4% high, etc. So these were significant biases being obtained. As well, even the intercepts were significantly varied from 0. And then he calibrated each of the commercial immunoassays with this calibration set, and now reassayed them, and now could obtain values, slopes between the two values are very close to 1, and therefore demonstrating that the standardization of this assay can be applied to these commercial assays. And so this is very encouraging. You can see the slope is very close to 1, as well the intercept is very close to 0. Now he then collected specimens from specific patient groups, which were, and then tested these as a verification panel. So the patient groups he collected were patients with 3rd trimester pregnancy. There were 34 of those. He collected plasma or serum from 28 patients who were undergoing hemodialysis, and 34 patients who had been diagnosed with osteoporosis. And then he assayed them again by the immunoassay and LCMS and compared their results. Now what I'm showing you here are the scatter plots from both the calibration panels for each of the assays on the left, and then the effectiveness the scatter plot on the right. So first of all, let's still look at the calibration panel. And why you can see, say, here you see the architect versus LCMS and all the centaur versus LCMS. Even in the calibration panel, you can see that there are patients who are significantly different from the line of unity, although on average the line of unity or the relationship, the equation described, basically overrides and sits onside the line of unity. So as a population group there is very good, excellent comparability between the two assays. But for individual patients there are significant variances, and this is an issue which will stick with us providing a clinical service. And it's my view that the manufacturers of these immunoassays should be able to tell us what is the variance, what is causing this variance in some individual patients, and therefore be able to help us provide an improved service. And of course we should know, and we should be on the lookout for values which for some reason or other we think are not being accurately assayed by an immunoassay system, if that's what we're using in our laboratory. And then on the right, he went to the effectiveness panel with these specific patient groups. And now you see that there is still significant variation from those patient groups, but from the line of unity. So the calibration and the standardization program has not been able to correct all patient groups in these immunoassay systems. And again, I'll just show you on the next slide for the other 3 systems, and the same evidence, the same interpretation is there, except perhaps for the ISIS, where there was, even in the effectiveness panel, there was an achievement of, on average, of the line of unity in those patient groups. So what are the sources, what are the factors affecting automated immunoassays for serum 25-hydroxy-D? Well, we saw that the patients with the 3rd trimester pregnancy were significantly different from the MS values, and they had much higher vitamin D binding protein levels than the other patient groups. So it would appear that vitamin D binding protein, or the variation in vitamin D binding protein amongst patient groups, is likely to be a significant component of this variance. The hemodialysis patients were also significantly different. Their specimens were uremic, And as well, vitamin D metabolism is disturbed or often disturbed in patients with renal failure, with high probability of increased levels of the catabolic component, metabolite 24-25 dihydroxyvitamin D. And that metabolite very often cross-reacts in immunoassay systems, particularly immunoassay systems that are using the vitamin D binding protein as the binding protein. As well, there are other issues which still are affecting the clinical serum 25-hydroxy-D assays. One is the serum measurement of serum 25-hydroxy-D2. The serum specimens used for the standardization protocol largely did not contain 25-hydroxy-D2. So the standard protocol hasn't been as evaluated for measuring 25-hydroxy-D2. As well, the NIST standard reference material 972, which contains 25-hydroxy-D2, cannot be used in the immunoassays because there are matrix effects. That 25-hydroxyvitamin D2 was just added to whole serum, and as I mentioned previously, this does not equilibrate. So when 25-hydroxy-D is added to serum in vitro, non-extraction assays provide erroneous results, and we don't know the basis, but presumably because there's no equilibrium with vitamin D binding protein. And then even in mass spectrometric assays, there is the problem of the impossible interference from 3-epi 25-hydroxy-D. 3-epi is the one hydroxyl group being in a different conformation than that occurs naturally. And many of the LC-MS-MS assays do not separate 25-hydroxy-D from 3-epi 25-hydroxy-D, and therefore it overestimates 25-hydroxy-D. Now, we don't know the clinical role or the physiological role of 3-epi 25-hydroxy-D. So therefore we don't know how to interpret their results. We don't know whether they should be combined with the total serum 25D or whether they do not have activity and therefore they shouldn't be. So higher levels are detected in young and neonates, and it's often higher when the 25-hydroxy-D levels are higher. It's not apparent, not measured by immunoassays, but as noted here, we do not know whether it has a physiological role, and we don't know how to interpret value. These are areas of research and investigation that are currently underway. And then the final difficulty that we have in interpreting 25-hydroxy-D is whether we should be interpreting and reporting the total 25-hydroxy-D or whether we see that whether we should be reporting a free or bioavailable 25-hydroxyvitamin D. Some interesting data from one particular group have been published over the last few years, since 2011, where they found that there was a better correlation with bone mineral density in young healthy adults with the free or the bioavailable 25-hydroxy-D rather than total serum 25-hydroxy-D. This same group found that there was a better correlation with mineral metabolism for bioavailable 25-hydroxy-D in hemodialysis patients, and then they also reported that bioavailable 25-hydroxyvitamin D may be a more appropriate as a cross-racial marker of vitamin D sufficiency. However, these data are controversial. They have generated considerable amount of literature and discussion, particularly around the assay for the D-binding protein that they use. And therefore, for those of us who are providing a routine clinical service for this assay, it's unlikely that we will be including it in any time in the near future. So just to clarify the free hormone hypothesis, the 25-hydroxy-D is a steroid prohormone which circulates bound to the vitamin D binding protein and albumin. There is an unbound fraction, the so-called free fraction, and it's present at very low levels. The bioavailable 25-hydroxy-D is 25D bound to albumin plus the free level. And Powell and colleagues calculated the bioavailable 25D levels from measurements of total 25D, measurements of the DBP, and then modified the Vermeulen equation, which was originally developed for the calculation of bioavailable testosterone. It's certainly been recognised that polymorphisms in the gene for DBP provide different structures of D-binding protein, and the concentration of these different structures impact on 25-hydroxy-D biological activities when assayed in vitro in macrophages. So there has been some evidence that this is important as a biological determinant of activity in some systems, but certainly we don't know it in all systems. So now I'm going to move on to the question of interpreting 25-hydroxy-D values. Every clinical laboratory report must include reference concentrations to enable interpretation of the patient value. We currently use two practices for the various assays that we provide from a routine laboratory. One is to provide the range for a healthy population, and so for sodium or something or potassium, we will report a value on a patient and be able to allow the clinician to interpret that value in terms of the values for sodium for health. In other assays, we report critical levels for disease. So for the reporting, for instance, of prostate-specific antigen, we have values that are predictive, that have a higher risk of prostate cancer as opposed to a lower risk of prostate cancer. And so that's a critical level for disease. Now, for serum 25-hydroxy-D, if we report simply a reference range based on a healthy population, that range simply represents the UVB exposure of the population that we chose. And that does not necessarily indicate that this population has appropriate levels for health. And of course, therefore, our reference ranges determined in this way, they would vary with latitude and with season. And yet, we have no evidence that there's a variation in the biological requirement for vitamin D in varying with latitude or season. We think we all need the same amount. So using that type of approach for reporting patient serum 25-hydroxy-D levels is inappropriate. However, there may be one exception, and I'll just discuss that briefly. This study was conducted and published recently, 2012, and it took the approach that humans evolved in equatorial Africa, and that was therefore where the requirement, the biological requirement for 25-hydroxy-D for our body arose. And therefore they went to equatorial Africa and collected blood from the Maasai and Hadzabe tribes who were still living a traditional agricultural lifestyle. And there they found that the values of serum 25D were very much higher than those which we now encounter in clinical practice. And therefore, if we were to derive a reference interval from this population, saying that, well, this is the population under which humanity derived, then we would have a reference range of something like 32 to 60 nanograms per mil. And of course, that's speculative, that's assuming other factors, but that would be one approach to take. However, the best approach in my view, and something that I've been pursuing over many years, some 30 years of working in the clinical laboratory, is to identify critical levels of serum 25-hydroxy-D required to avoid disease. And this is a highly controversial subject at the moment. We've had recently the Institute of Medicine report suggesting that levels that greater than 20 nanograms per mil are satisfactory, and we've had other expert panels presenting reports suggesting that 30 nanograms per mil is the minimum level required for health. Now, let's go through the evidence for these critical levels. There is certainly general agreement that serum 25-hydroxy-D levels below 8 nanograms per mil represent severe deficiency. And the general agreement is based on data such as those obtained here. So here you see a table of 25D levels in nanomoles per litre, then nanograms per mil, then the ionised calcium, plasma ionised calcium level in millimoles per litre, and in the far right column there's the PTH. Now these data were obtained from patients presenting to a clinic who had all low 25-hydroxy vitamin D levels. That is, they were less than 16 nanograms per mil. And when the patients were analysed, their data were analysed on the basis of varying the 25-hydroxy-D levels, you can see that as the 25D levels increase from 0 to 4 nanograms per mil, there is a very low plasma ionised calcium, 1.14, and a very high PTH level of 15.6. So at that level, most of these patients have hypocalcemia, which is considered a marked indicator of vitamin D deficiency. However, by simply moving these patients or their 25D levels to slightly higher levels, say above 8, and 8 nanograms per mil, then they achieved ionised calcium levels which were much closer to adequate, 1.18, and PTH levels much lower at 5.7. And so what we can see is that there is a rapid, at levels below 8 nanograms per mil of 25D, there is a very high probability that patients will demonstrate hypocalcemia. And further data like this are shown in a study published from Indian colleagues from New Delhi. And here they had patients, young women, presenting with what they diagnosed as biochemical osteomalacia. And this was done on a number of criteria. And the mean value for the patients, the mean serum 25D value for these patients was around about 14 nanomoles per litre, so around about 5 to 6 nanograms per mil. And their PTH level was quite high at 26 picomoles per litre. Now, these researchers also collected blood from the sisters and brothers and mothers and fathers of these patients, and they assessed them for biochemical osteomalacia. And they found that by simply when the 25-hydroxy vitamin D level rose from about 5.8 nanograms per mil to about 7.3 nanograms per mil, that's with the sisters, that the incidence of biochemical osteomalacia was decreased by some 75%. And that by raising the serum 25D levels just a little further, up to 30 nanomoles per litre, then the incidence of biochemical osteomalacia again decreased even further. So therefore we're saying that these data are consistent that osteomalacia at the level of, and there are other data on biopsies of bone, which is the definition of osteomalacia, the diagnosis really depends on that, that osteomalacia is resolved at levels of around about 8 nanograms per mil of 25-hydroxy vitamin D. So therefore, we have this general agreement that less than 8 really represents severe deficiency. However, there's also been generated over the last 30 years that recognition that the risk of osteoporotic fractures increases with serum 25-hydroxy-D levels below 20 nanograms per mil. And again, we have a large amount of data. So here you see a forest plot of case control studies conducted over many years. The first one from 1970, which doesn't show an effect, and possibly in 1970, the colleagues, the researchers, could not really measure 25-hydroxy-D at that time. But since that time, every other study has demonstrated that the patients with fractures have lower 25-hydroxy-D levels than their controls with age-matched controls who don't have fractures. Now, to look at the actual level, here are data from a couple of recent papers, one from the Journal of Clinical Endocrinology and Metabolism in 2009, and there they found that the rate of bone loss in older community-dwelling men was significantly less when the serum 25D levels were between 20 and 30 nanograms per mil, compared to the men whose levels of 25D were between 15 and 20 nanograms per mil. So by just simply moving above 20, here we have a critical level of 20 nanograms per mil for 25D, determining the rate of bone loss. In postmenopausal women, in a study published in 2008, the risk of fracture was markedly increased when the serum 25D level was less than 19 nanograms per mil, compared to women with a serum 25D level of around about 29 nanograms per mil. So here again we see this level at around about 20 nanograms per mil, where there is a change in the risk of osteoporotic fracture. And of course those studies are sort of just association studies, and they can only be demonstrated, the causal relationship between 25-hydroxy-D and risk of hip fracture can only be demonstrated by randomized controlled trials, and these fracture studies have been conducted, and here you see forest plots for randomized controlled trials conducted for hip fracture and other non-vertebral fractures on the right. And only when the only when the vitamin D supplementation is at a sufficient level, that is between 800 and 2,000 international units per day, given mainly, most of these studies gave calcium supplements as well, so given in combination with calcium, do we see a significant reduction in the risk of fracture. Now there are a lot of data, or data from a lot of patients now, which provide this same answer. So again, here's a study from Tang, published in The Lancet in 2007, collecting data from some 53,000 patients. If they were given calcium alone or calcium and vitamin D, there were significant reductions in the risk of fracture, and there was no statistical difference between calcium and calcium vitamin D in this meta-analysis. However, they did find that the vitamin D dose had to be greater than 800 international units per day to achieve a significant reduction in fracture. And in the bottom study, the DIPART group, published in the BMJ in 2010, there again, 68,000 patients, data from 68,000 patients being studied, that if calcium and vitamin D trials were assessed, again, there was an 8% reduction in the risk of fracture, statistically significant. However, if vitamin D alone was given, there was no effect on the risk of fracture in these patients. So therefore, there is this recognition that the risk of osteoporotic fractures increases when serum levels are below 20 nanograms per mil. And the current debate and the current controversy is whether there are any benefits that can be demonstrated for serum 25D levels at 30 nanograms per mil that are not obtained at 50 or 20 nanograms per mil, 50 nanomoles per litre. Now, there are some data, here are data recently published, 2013, on the risk of vertebral fractures with 25D levels. And here you can see that the patients were divided into those who had 25D levels less than 20 on the left, to those who had 25D levels greater than 30 on the right. And the patients were also divided into those who had an elevated PTH or had a normal or suppressed PTH. And you can see that those patients who had the elevated PTH and values of 25D less than 30 had an increased risk of vertebral fractures. Now, these are in women who are just 53 to 70 years of age, and therefore they are younger women than have been included in the previous trials. And so these are very interesting data to suggest that an adequate vitamin D status is required in order to reduce the risk of fractures even in middle-aged women. Now, these clinical trials, particularly the fracture trials, have also been used to study the effects of vitamin D supplementation and calcium supplementation on the risk of falling. And here are data from a meta-analysis demonstrating that adequate doses of vitamin D, 700 to 1,000 international units per day, compared to lower doses of vitamin D, are necessary to reduce the risk of falls in subjects living both in institutions and in the community. But this is with a group who are significantly older. We might call these an elderly group. And then finally, and most importantly perhaps, is vitamin D supplementation reduces the risk of premature mortality in frail elderly subjects. So here's a forest plot from 18 randomized controlled trials demonstrating that through the period of this trial, the subjects who received the active ingredient, the vitamin D and calcium supplementation in most of these trials, they had reduced number of deaths compared to the subjects who were included in the placebo group. And so, of course, that's a very important endpoint. And the cutoff level between these who had the reduced mortality during the trial, that's why I call it reduced premature mortality. I'm sure each one of these subjects died in the end. Then so they had reduced premature mortality was achieved with levels of around about 31 nanograms per mil for 25-hydroxy-D compared to those who died at a levels about 15 nanograms per mil. So therefore there is some evidence that there are benefits at levels of 30 nanograms per mil compared to 20 nanograms per mil, but at this stage we're still collecting those evidence and we're still fighting a lot of scepticism amongst our clinical colleagues that these benefits are real. So why would we need different critical levels for different diseases? So in osteomalacia, we can avoid osteomalacia by having a serum 25D level greater than about 8 nanograms per mil, whereas to avoid reducing the risk of osteoporotic fractures, we need a level of 25-hydroxy-D greater than 20 nanograms per mil. Well, as I've previously showed you in this metabolic pathway for vitamin D and its activity, the kidney synthesizes a plasma 125D, and where that's in the kidney, and produces endocrine activity. But also there is an autoparacrine activity from 25D, whereas there is the levels are of where the 25D is converted to 125D within a cell. And we know this occurs in bone cells, it occurs in macrophages, and it occurs in skin cells and in brain cells in a number of various tissues. So therefore our biomarker is a substrate for an enzymic reaction. It's not a reaction, it's not a biologically active substance in its own right. The product of any enzyme reaction is dependent on the level of the substrate and the level of the enzyme. And so we have these two factors which can determine the product. Now, we know that in the kidney, it is very capable under particular conditions, particularly as shown here, vitamin D depletion and a low dietary calcium, to induce the expression of the CYP27B1 gene by some 500-fold, whereas no other tissues have been shown to be able to induce the enzyme to the level that the kidney has done. And we can see that under certain circumstances, this histogram shows the level of CYP27B1 activity in a range of tissues, and under conditions of adequate calcium, the kidney is not the highest level. Other tissues have higher levels, but under certain circumstances of hypocalcemia and a low vitamin D status, high PTH, then the kidney is capable of upregulating that expression to a very high level. And so therefore the questions of the ability, we would need less substrate with a high level of CYP27B1 enzyme in the kidney to continue making adequate 125D than we would need in bone cells, where they do not have such a high level of the enzyme under those conditions, and therefore we need to maintain a higher substrate for the CYP27B1 in these other tissues. So in the wider health context, it's likely that the physiology of vitamin D in non-renal tissues operates through similar activities as that for the bone cells, with local synthesis occurring. It's probable that the local synthesis of 125D in non-renal tissues may require different critical levels of serum 25D for optimal health outcomes, depending on the level of the enzyme CYP27B1 in those tissues. The current trial data indicate that levels around 30 nanograms per mil can reduce the risk of falls and premature mortality. But this controversy around recommending a critical level of 25D at 30 nanograms per mil largely arises from a lack of strong evidence, and further evidence is required to provide such convincing to all of our colleagues in the healthcare industry. However, I think as analysts and providing a service, a clinical service, we must also think about the issues of the nature of our assays. And so while we recognise that a level of 25D level of 16 to 20 nanograms per mil is greater than 20 nanograms per mil is required to reduce the risk of fractures, we have to think, can we detect confidently the difference between, say, a level of 16 nanograms per mil and 20 nanograms per mil? We've shown, or we have data to indicate that there is a significant difference in the risk of fracture between those levels. And the other question, of course, we have to consider is whether we would be doing harm by recommending patients have levels of some 30 nanograms per mil. Now, in my view, we cannot confidently detect the difference between 16 and 20 nanograms per mil. So therefore, I believe we need a cutoff point which is higher than the 20 nanograms per mil, because there'll be errors around that. And some patients at which we would say would be 20 or 21 nanograms per mil might actually be at levels of 18 nanograms per mil. And that might be clinically important. The other question is, are we doing harm by recommending higher levels? And I think that the data certainly are clear that there is no harm at levels around 30 nanograms per mil. Very large numbers of the population have such levels through their exposure to sunlight and through their own lifestyle activities. Certainly there are toxic levels, and those toxic levels, we are unsure of the lower limits of that, and again, that is a subject of great controversy. So levels of 60 or 70 or 80 nanograms per mil, there may be some evidence of toxicity even at those levels, but certainly levels of 100 nanograms per mil there would be evidence of an increased risk of toxicity. So I finish there, and thank you very much for your attention, and very happy to have any questions that you might have put forward and entered. And I'll try and look at those now. Okay, so we have a question from someone that says, does it make clinical sense to report 25-hydroxy D3 and 25-hydroxy D2 separately? No, I don't believe it is. It's the total 25-hydroxy D that you want, that the clinician and the patient is interested in. And it's a question of providing that. There might be some issue at some stage whether to ask or to provide an answer as to whether there is a problem or whether the patient is taking a D2 supplement or not. But that is not what is of great interest. It's really the total 25-hydroxy D that is required. And currently this is not possible by immunoassays. This is only possible by a chromatographic method, whether it be HPLC or liquid chromatography. Yes, in liquid chromatography. Now, I have a second question from Christine in Elizabethtown College, and she asks, in clinical studies, have there been any correlations between levels of stress and vitamin D levels? Now, that's a very interesting question. There was a Nobel Prize awarded to a scientist, Elizabeth Blackburn, who discovered that the stress and the longevity of cells was determined by their telomere length, by the length of this section of chromatin called the telomeres. And they have done assays now demonstrating in both patients and in experimental models that the telomere length, as stress increases, telomere length decreases and therefore longevity decreases. And in fact, in chronic diseases such as diabetes, they've been able to demonstrate that telomere length is decreased in patients who have diabetes, etc. Now, there's been a recent study demonstrating that higher 25-hydroxy vitamin D levels are associated with increased telomere length. And therefore, there may be, from this study, one might say, well, are these people, is there an effect of longevity or increasing our telomeres, which is associated with providing us with a longer lifespan? So the issues of stress it's an experimental area, it's an area of interest, certainly, but of course one could also imagine, and this is the whole issue with vitamin D status and the question of association with other diseases, is it a biomarker of a healthy lifestyle? Is it a biomarker that the person who goes out and is doing exercise, walking, and who will therefore get more UVB exposure, they will therefore have a higher serum 25D level, whereas and the person who is sick, staying inside, will have a lower 25D. So that would be just associations and not necessarily a causal link. And so that's the key issue, the key question about whether the issues of stress and longevity and the wider health benefits of vitamin D, are they overblown? Are they exaggerated? Because all it is a marker of a healthy lifestyle. Now, of course, to have a healthy lifestyle might be good, might be worthwhile having. But you probably don't need a serum measurement of 25D to tell you that you've got a healthy lifestyle, that you go out walking. Probably just asking questions might tell you that. Okay, well that seems to be all the questions, so I think we can finish off there. And I thank you for your interest and your attention. Thank you very much.